Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eneagizijig, enekukamigak kanadang âgés odapinagig endawajin odawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bienvenue. Bonjour tout le monde. Je m'appelle Doug Archibald. I'm the Director of Research and Innovation with the Department of Family Medicine. I guess it's maybe still appropriate. Happy New Year. 2003, you can see in our message, we've got our new message for 2023. It's my pleasure to be the moderator of today's session. We have two speakers from the Montfort Hospital, Dr. Joanisse and Dr. Rohit Gandhi. I'll first of all introduce Dr. Joanisse, family doctor, involved in geriatrics, especially in rehabilitation and orthogeriatrics throughout his career. Now retired from acute care, but still involved in research through the Institut de Recherche de Montfort. He's an associate professor at the Department of Family Medicine here at the University of Ottawa with an interest in orthopedic care and needs of elderly patients. So, John, I'm going to hand things over to you. I think Mia's going to be sharing your slides. Once she's done that, floor is yours.
Good, thank you. Welcome all. On a snowy morning, I think virtual is very appropriate. I think otherwise we probably would not have had a meeting. Looking at my driveway, it'll be a while before I get out of here. So, les Inoubliables, next please. These are the Unforgotten. So these are folks who are awaiting arthroplasty. I could well be one soon, so my conflict of interest is obvious. It's very self-serving. So I'm old and I'll probably need another new hip soon. So next, please. So just to outline the problem before getting to the unfocused research question, which is usually my problem, focus. So the problem is that there's a 12 to 18 month wait for total knee and hip arthroplasties. And the main reason for that at the present is a lack of staff. This existed pre-COVID and it's obviously gotten worse. The hospitals, because of the way they're paid and also the availability or non-availability of beds, are favoring same day or hospital stay, 1 day surgeries. So the older folks are obviously at a disadvantage. So because they've got an increased likelihood of being admitted. They're more complex. A lot of them are frail, but even those who aren't frail often have to wait. And of course, they have social requirements. They need home care more often than perhaps a younger person would. Next, please. So we did a lit review. I had a few dollars left over from another project, and I hired a medical student to do a lit review on this, and we'll go back to it later. But the elderly benefit as much in improvement of function and pain relief as younger patients. That's not new. So in qualities, it's as good as the young people. These are excellent surgeries, and they should really be available to all who want them and need them. And with the advancements in care, perioperative care, anesthesia, the surgical techniques, they can be done safely in the older people. But of course, they require more intensive care that has to be carefully done, planned, and often they have to be done in hospital as well. Post-op care has to be available for a number of them. Next, please. So the production line is that the older, and we're talking mostly about osteoarthritic patients here in the elderly. So they're referred by the family physician or nurse practitioner. They are evaluated by a physiotherapist at the regional clinic. And then there's a judgment made as to whether they are an appropriate surgical candidate or whether they should look to something else for the two main reasons for arthroplasty, which are one, function, and two, pain. So assuming that they're accepted, they're seen by an orthopedic surgeon, placed on a waiting list. And the way that things function, there's a priority list from 1 to 4. And generally speaking, they're 4s with some 3s. But what then happens is that they hear nothing for months. And the reason I got interested in this was that a neighbor who was really a low risk heard nothing for a year after he was accepted. And he phoned around to figure out where the heck he was, and he couldn't find anybody who could give him an answer. Neither his family doctor, neither the hospital, the assessment clinic, the orthopedic surgeon. No, you're on the list. That's all he could find out. Next, please. So if we look at referrals as of November, these are the numbers for the Ottawa area. And unfortunately, not all the hospitals were reporting, but this is what I could find on Health Quality Ontario. So you can see that there are two waits. One is the wait for assessment and for evaluation. And there you can see that there's quite a long wait. For some reason, the priority 3s are even faster, are quite a bit faster, but generally our older folks are priority 4. The second wait is for the actual surgery after the patient has been accepted and judged appropriate for that surgery. And once again, you've got a really variable wait, but at least 3 months. So if you total that all up, there's no way you're going to get done in less than 6 months. And generally, it's quite a bit longer. Next, please. That's for hips. The same sort of thing applies to knee replacements. So these are all elective. And once again, the information is not all that complete, but you can see the same kind of pattern. I didn't put the priority 1s in there because they're done usually much quicker. Next, please. So the lit review, it's really interesting that there are things written as of COVID on the effects of the delay on the patients. And if we look at just the psychological, the mental health part to begin with, this was this feeling of abandonment and hopelessness was what I ran into when talking to a couple of patients. And unfortunately, there's almost a built-in ageism there, built in the sense that the patient themselves feel that, well, you know, maybe somebody else should have it, and maybe I shouldn't bother them with this, or else I'm no good. That kind of thing creeps into their conversation. Already, even without this, there's a known association in the literature between depression and osteoarthritis. That's putting everything aside. So we can imagine if we add on the previous idea, things then unfortunately sink into some anxiety and uncertainty. In the worst cases, it makes them very negative towards the healthcare system and sometimes towards the providers. And I heard this from the orthopods with whom I talked, that they would unfortunately reap the benefits of the delay with some nasty things from their patients. What end up happening in some cases is the patient actually refuses surgery, says, no, I'm not interested anymore, even though he or she may be actually more deserving or needy than before. Next, please. The pain obviously doesn't get any better. There's often a problem with meds. Some of the patients will go elsewhere for non-medical care. So they'll, dip into the over-the-counters or go see folks who are maybe not legit. There's unfortunately an increasing loss of function and dependence in the family, and the quality of life obviously is worsening. The social isolation because of lack of function and pain is increased, and there's stress obviously on the folks who support them. Fragility comes into bear and is often seen as a complete block to be having surgery, and yet there's no question that if we can increase mobility, we actually reduce the fragility. The other thing is that if you're waiting a year, is that fragile patient whom I saw last year still the same patient as this year? What has happened in the interval? Has the patient all of a sudden not become fragile? Are his post-op needs the same? Next, please. There's not a whole lot of literature, as I said, on this sort of thing, but we managed to come up with some of it. So while the patient waits, his ongoing needs are addressed. How are they addressed? Well, they fall into different domains, and so there's the general medical care, including taking care of those who have a complex medical and issues and multimorbidities. There are also obviously needs that are specific to the osteoarthritis, and I mentioned them before, the pain and the functional decline, the actual reason why we're contemplating surgery. And then there's the psychosocial needs that I've outlined before. Next slide, please. So the question then is, in this grand scheme of a referral to surgery to post-op, what's the family doctor's role in this sequence? And this is actually what I want to explore in this piece of the big project. So what happens after the patient is referred? Is the family doctor informed of the progress of the patient along the production line? Is he or she still involved in the care, specifically with regards to what I mentioned before, that is the pain, but also the function? Or are the patients kind of lost out there somewhere? Is the family doctor involved in the maintenance and optimization of patient care during the wait? So the idea here is that if the patient is going to wait a year, and this project does not try to change that, that's not part of what we can do. Even if we tried, we probably couldn't. But why waste that year? Is there something we can do to actually optimize the patient? And is the family doctor involved in the post-hospital care? And next, please. There's a larger project, as you can imagine, involved here. It aims to look at each step along the pathway from referral to evaluation and finally to surgery. And what we found was that there wasn't a whole lot of contact between the different partners involved along the way. They generally don't talk to each other and are not aware of what's happening to the patient. Is that true for family physician? I don't know. So that's actually the key to this piece of the project. So these are the folks involved along the way. And what we'd like to do is to find out from their point of view, what can be done for this patient while he or she waits. Next, please. Obviously, the patient is the main part of this partnership. Some of the work that we've already done. So the whole thing, as I said, was triggered by informal discussions with affected patients. The orthopods were really interested from the outset because they suffer the slings and arrows of displeased patients. The hospital at Montfort are looking at the numbers. For example, the number of total joint replacements done over 70, how many were admitted, how long was their length of stay, that sort of thing. Those numbers are not available today, but they will be, unfortunately, next week. As I was telling Doug, I managed to free up some money from another project to hire a student for the literature research. And this same student has actually, thanks to the Affaires francophones, has a bursary in place to continue on with me. And we've already presented to the local physios who thought that, yeah, there's a need here. Next, please. So that's the next. Yeah, thanks. That's the larger problem. What's the family physician's involvement in the production line? So I talked about the funding. What happens after referral? Does the information flow back to the referring physician each step along the way? I know that the physio said, well, we send a report back to the referring physician, whether the patient is accepted or not. But I didn't hear that there was much ongoing communication thereafter. How about the patient himself? Does he continue to see his regular physician for his usual care? And what about the challenges caused by the osteoarthritis? Who takes care of that? Is there an ongoing communication flowing forward, that is from the referring physician, to keep the other members of the total joint replacement production line abreast of what's happening on? And finally, who communicates with the patient, which is where this all started? Next, please. So my methods are awful. So if you've got comments and questions, please. So we've already got the Department of Family Medicine approval to circulate a kind of a doodle to elicit some early comments about some of the questions that I've just raised with regards to the referral, the communications with other members of the team, their ongoing involvement in the care, and the family physician's overall experience with the referral of elderly patients for arthroplasty. What's their impression of how things are working? And again, the pandemic comes to play in here, but this pre-existed prior to the pandemic, and it will continue. The next step would then be to find those who might be interested in participating in a focus group, and there we would like as well feedback from the patients to have that in hand and pose it to the focus group for feedback. Next, please. So the focus group would explore in more detail the questions already posed, look at the feedback of actual patients, and then brainstorm ideas as to how the family physician could contribute to better the patient experience along the line. But the whole thing here is that I'm wary of adding work to the family physician or to the family physician's office. It's a real concern of mine, and I know I will get pushback because of that. So the idea came to me that it seems to me that there's somebody missing along the way here who could maybe rally and link all these folks together. And the idea that patient navigators exist once you get into the hospital system, but there is not such a thing prior to hospitalization. I didn't find anything in the literature that addressed the waiting period and how to make it bearable. It seems that's kind of a void. Next, please. So as you can tell, the timelines and the funding requirements are still to be worked out, especially for the larger project. The provisos here, once again, is we're not going to increase the flow through speed of surgeries. We're not going to affect the waiting lists or influence patient selection for surgery. That's not the goal. And obviously, what we don't want to do is increase the work of anyone, be they family docs, nurses, physios, booking clerks. It's essentially to add empathy to arthroplasty. That's a nice catchphrase I just thought of. So that's the idea, and some of it is not all that well focused, but I think we're making progress, and each step along the way we seem to be hitting a nerve, and so I think the project has some possibilities. Thanks for listening. I'll welcome any questions, comments, or suggestions.
Thank you very much, John. I think there's certainly a role for family medicine here, and our comprehensive family physicians online will have some thought here. And I do have a question. I'll save it for later, sort of around methods and some thoughts there. But I see Claire's got her hand up, so I'll turn things over to her.
Hi, bonjour, Jean. Good morning. So
Hi.
Claire Liddy, hi, chair of the department. I also am the one of the executive directors for the province of Ontario for e-services, which includes referral, looking at referral. So 2 comments, one as the chair and one as the one of the e-services e-referral leads. So maybe I'll start with the e-referral. This one would be ripe for doing e-referral and enabling those referrals actually to be going into the system. And the reason why it links to that is that the e-referral platforms that are available all have the patient communication piece in it already built in. So that one, so that's something to explore. It's all funded right now for any specialist to sign up. I know there's quite a lot of work. I don't know what the status at the Montfort is. But in terms of system level improvement, that's definitely a possibility. The second thing is with chair of the department hat on, but also with that. So this is completely a fundable project. I think I really love how you put it together. I want to emphasize again for all the folks on the phone that you did a lit review. So had these questions, it came from a patient, your neighbor, you know, thinking about it, and then, well, let's look and see what other people have done. And that is so, it's the beautiful approach, and it is really what is necessary. So I congratulate you for doing that and being resourceful to bring on a medical student to do that part with you. Where you're at right now then is lots of questions, and the empathy piece in terms of the patient experience, I think, is critical. Those questions are all, as I said, fundable from a methods point of view. I would just encourage you to focus and dissect it down even more. So what would be the most important piece to me? Doing trying to understand the patient experience more and actually going to a co-design type of method with the patients who actually are on the waiting list. Waiting, I think would be very, very rich type of study, and that would then inform who needs to be involved, as opposed to going the other way around, which is what I understood, which was a survey to family doctors to see what they are, thinking about. I might have misunderstood. Anyways, the department has, this would be great for a prime grant. I also would encourage we could actually help support another summer medical student. And working with the Institut Savoir Montfort, we do a lot of partnerships. So I think there's a locum support fund. Doug, what else would there be? There's also the Institut Savoir Montfort, like the Montfort Academic Medical Organization, funding opportunity. And so we've got the research support unit here. We have quite a bit of funding that would align beautifully with what you're wanting to do. And so I invite you to follow up. I think you should do a follow-up meeting with Doug and I about what the opportunities are. And excellent, beautiful project. And as I said, like your tagline at the end about the empathy piece, I like keep going with it. So that hit a nerve for me personally, and that's, I think your work has a lot of potential, and you've already done a tremendous job. So congratulations. A real pleasure to start the day like this.
Thank you. Actually, the patient piece we were planning on doing simultaneously, and then so it's actually key. And as I've said, I've done it kind of informally, and I said, oh my God. There's one piece that I didn't bring up, and that's of course the Premier's announcement that they're going to do hips and knees in outpatient. I'm not sure that's going to change a whole lot of what's going to happen to the older folks. Fortunately, whatever, the hospitals are paid by bundled care, so they have no advantage to admitting somebody to hospital. So I'm not sure that things are going to change a whole lot for the older folks, and I think the older folks are not going to be done in these free clinics. Probably shouldn't be done. So that's sorry, I meant to mention that earlier because it could make the whole project irrelevant, but I don't think it does. Thank you, Claire. Your suggestions are excellent.
Yeah, I'd sort of like to echo that, John, around the co-design. To me, this really begs for a qualitative intervention, And certainly the power of the narrative is very strong. So certainly in terms of funding, Claire identified the local opportunities for sure. Perhaps more, I saw that when Claire mentioned the ESM, Sharon put a thumbs up there. So that's great. So that's a great opportunity. And then Claire Kendall's also indicated Janus grants. And there may be possibly some other opportunities that come up from the College of Family Physicians too. So I see Owen first and then Prisa.
Hi, I get this question all the time. Someone who's been sent off. Now what's happening is a physiotherapist are preemptively saying you should refer this patient to the total joint replacement clinic, which means the bottleneck is getting worse. And then it's what happens is patient develops AFib, they end up being on a NOAC, so their medication requirements get more complicated. Then on top of that, people say, I'd like to see this specific orthopedic surgeon. Is it still not possible to be referred to him? Because some orthopedic surgeons are better than others. And this is not factored in. I don't want to be the one dealing with phoning people up. The idea of some sort of navigator, a phone number navigator sounds great. I'll be able to say, this is the number, you find out where you are in the stream. I don't have the resources to do this follow-up for you. I'll look after your new problems, your kidney failure, your diabetes, your arthritis, your atrial fibrillation, but I can't do it all.
Thank you. That I totally agree. Now, the original patient who triggered had nothing wrong with him, but he just didn't hear anything. All he would have needed was a phone call or some communication on a monthly basis. Say, you're still on the list. Is there anything we can do to help you? We all think of the very sick, frail patient, but a whole bunch of them are not. They're well. They just need to be informed. They are the unforgotten.
Thank you. Prisa.
Good morning. Thank you very much. This is very important right now. And so I'm a family doc, and I have many patients who are struggling while they're waiting for their surgery. So thanks for doing this talk. I think from my perspective, we're actually inviting the folks from Queensway for the annual refresher for family docs to come and present precisely this talk, because there's a lot of confusion as what happens to the patients. So I'm just wondering, given your influence where you are right now, is there a possibility to just give also feedback on the front of how much workload is put back on the family doctors from the referral? Because what happens is that I've taken my x-ray, I've done all my due diligence, then the patient's time comes up, and then I get another note that sits in my mailbox that is full, requesting another round of x-ray, another round of blood work. I don't think this is my job. And I think that then the patient gets the service, because when they go to these centers, they have all the facilities. Why is it that they can't have their one-stop shop, get everything done there, and reduce my workload? Because I'm busy managing their pain and their kidney and their heart. And when we call it a central referral, that means it is truly a central referral and management. So that's one piece. The second piece is that, yes, we get some note from the physiotherapists, but sadly, they're often very brief. They give us no information as how we can help the patient along the way, and often, sadly, illegible, actually. I don't actually know what they've done. There are PDF forms that are extremely difficult to navigate as well. So just feedback.
This really helps with the questions that we want to ask the family docs. And as I said, the last thing I want to do is add to your work. If I do that, take me out and shoot me. It's crazy. Or to the hospital's work, but somebody's got to do something along the way. Thank you. That's very helpful.
Okay, just quickly, Richard, and then we'll only move to our next speaker.
Yeah, and I'll just say, because it's going towards the central intake, so I'm going to be joining the central intake steering committee for the entire region as the primary care rep. So as you guys have suggestions for things you want brought forward to that, and I'm hearing specifically that as people are waiting on Bliss, can we get regular updates to the patients? Seems like a low-hanging fruit suggestion there, but any other ones that you want me to bring forward there, I can also be a vessel. So that table has all the CEOs of the regions, and hopefully it's rolling out the endoscopy across the Ottawa region very soon. That's already live in Pembroke, but just letting you guys know you can link things to me as well.
Super, thanks for that, Richard. This is gathering a lot of conversation. So perhaps John, if you want to put your email in the chat, people can reach out to you, and please keep the chat going. That's what it's there for. But we're going to change gears now a little bit, and I'm going to introduce our next speaker, Dr. Rohit Gandhi, an emergency physician and clinician researcher at the Hôpital Montfort. Dr. Gandhi has several publications in audit and feedback research, and he was granted the New Innovator Award from the Department of Innovation a couple of years ago. The New Innovator Award with the Department of Family Medicine a couple of years ago, and has also received an ESM research grant. And Dr. Gandhi is also a recipient of the Ottawa's 40 Under 40 Award. So, Rohit, I'm going to pass the floor to you.
Oui, bon matin tout le monde. Thank you, Doug. Everyone can hear me and see my screen?
Yes.
Great. All right. So this is, the title of my talk, Don't Just Do Something, Stand There. And it's sort of a little bit of a highlight of choosing wisely at Montfort and sort of my choosing wisely journey, through medical school and residency and now as staff. So I wanted to share with you a bit about my experiences with that. So just for disclosures, I'm not affiliated with Choosing Wisely. And as Doug mentioned, I do have the DFM New Innovator Award, which is helping support my research, as well as the Institut Savoir Montfort research grant. So I have some objectives for today's presentation. Yeah, one of them is obviously to better understand the Choosing Wisely movement and really the latest updates in that, because there's a lot going on lately. And to identify opportunities for all of us to reduce what we call sort of, over testing or care that's, less useful, and then sort of integrating that evidence into practice and building consensus with patients to reduce this over medicalization. So there's a few, reasons why we practice the way we practice, and I'll just sort of put a few of them on the board. Many of you probably have heard that, especially if you've had a learner sort of ask why we do something. There's a lot of reasons that sort of go into our decision making as clinicians, and I think this is something that we really want to reflect on and try to understand, what drives us in terms of our practice patterns. So just in terms of some context, I don't think a lot of you are unfamiliar with this, but healthcare costs are on the rise. The system's capacity is really strained, and in the past 15 years, its expenditures more than doubled, and then we predict by 2037 that about 97% of all provincial revenues are going to be spent on healthcare. A lot of studies in the past have sort of explored system level changes to control cost, but physician level solutions haven't been well explored. We can always argue whether or not that's the most important area, but as gatekeepers to healthcare, we have a huge influence on its resources and its costs. And really that, we don't have a system necessarily designed to learn to manage resources as well as we probably should. We receive little training on that, and a lot of people argue that it's our ethical responsibility to sort of improve on that. So you'll notice a lot of that was focused around costs of care, and I think that was probably one of my first mistakes when I started my career of Choosing Wisely, and I'm going to get back to that in a second. But just in terms of a bit of background, this was founded as a movement in the US in 2012 and launched in Canada just shortly after. It's largely become a global imperative now in European countries, as well as moving into the lower and mid-income countries as well. And I always like to sort of refer to this study, which is a 2017 study in Canada that reported that up to 30% of the treatments, tests, and procedures that we do are potentially unnecessary. So that's a striking number, almost a third. Some of the key findings of that report highlighted things in certain regions where the tests were done, having unnecessary testing like X-rays or MRIs or CT scans. We talk a lot about sedative use in the elderly and how that increase in prescriptions for these sedatives are on the rise, benzodiazepines, and things like preoperative testing. And I think that sort of lends itself a little bit to this morning's excellent talk as well, sort of that over pre-op testing. And so these are just, again, in terms of primary care, some screening tests, transfusions, and, and this is in sort of my wheelhouse of the emergency room. So it sort of hits all of us in different ways. And again, they've ended up evolving to have, over 440 recommendations, being across multiple learning centers and schools, and having pretty large public campaigns. So you've seen some of them. They have some pretty interesting advertisements where sort of describing or starting the conversation with our patients more isn't always better. So that's sort of, where I started in my journey. I have a background in business, so I worked in the business world. And so when I came into healthcare, I was just surprised that, we didn't have a good understanding of the costs of things. And that's a very important consideration in industry. And that sort of led me to sort of my first research project. Do physicians really even know the cost of the care they provide? And the answer is obviously, or unsurprisingly, fairly poor understanding of cost. And it's just a function of our training and a function of doing everything we need for the patient. And I think as I progressed, I really ended up realizing that it has a lot less to do with cost, and the focus was really in the wrong area. And that took a lot of learning and mentorship from a lot of other players who were involved in my career. They're really focusing on reducing testing in terms of keeping the patient in mind, to reduce harm, to improve healthcare outcomes. And if cost was a secondary benefit, I think that was sort of where my journey sort of began. And so the reason why I, grew in that journey was that, we have interventions, and there's a spectrum of different types of interventions. And I know a lot of you are researchers here and also understand this spectrum. But, education alone, just having physicians understand the cost of care without other sort of areas of improvement where we, provide performance measurement, audit and feedback, which is my area of interest, and other improvement projects, or whether we just do hard coding where you have no choice and you have to, follow order sets. There is a large spectrum of this, and sort of seeing where I fit and where I think the best intervention sort of falls and in this spectrum was an interesting sort of realization for me. And that's sort of where my interest grew in audit and feedback. And this is sort of a good example in the beginning of my career where I looked at sort of an Australian audit and feedback over 6 months of prescription rates and, for antibiotic stewardship, and sort of, just seeing the different levels of interventions. And you can see here, no feedback, education only, and then varying degrees of additional intervention, had an interesting effect on a reduction in prescription utilization, inappropriate prescription utilization. And so, that sort of led me to my first audit and feedback project in RED. And so I know this is a busy slide, but it really made me start to explore the field of audit and feedback and giving personalized feedback to physicians. So we took our group of docs here in the ED, we picked 2 interventions that had a lot of literature for proper utilization and a high level of inappropriate evidence against its use. And so we took urine cultures, for example, that were ordered, simply, because we added it on. We ordered it UA plus urine culture without having it, any symptoms that sort of went to the urinary tract or even had a positive urinalysis. And so that was one of the interventions along with rib X-rays. And so we identified these inappropriate use of certain tests and essentially, made a scorecard that sort of showed your ordering rates, where your peers are. And I think a lot of you have started to see this in family practice, but it was a really interesting exercise for me to not only support physicians with the education. So we made videos, we made interactive sort of tools to better understand why your ordering rates are or potentially why they are in a certain level. And so you sort of coupled that slide where we looked at different aspects of intervention and put them together to help really reduce our rates of ordering. And we still see this reduction persisting today in our departments, about 80% reduction in x-rays, rib x-rays inappropriately, and about 36% in 35.7% in urine culture ordering. So just, that's sort of a little bit part of my journey. And so after doing that project and looking a bit about choosing wisely, it's actually really interesting to see that a lot of what choosing wisely comes out with is actually borne out to show little change in the years that the program began in terms of actual outcomes. And I found that really interesting. And I mean, that's not the case, throughout, but it's a very interesting theme. Consequently, hospital level changes were actually sort of evaluated and have shown to have very successful and promising interventions at the hospital level or organizational level with the different toolkits that are available. And so that's why I wanted to highlight this slide, actually, because these are some interventions that have been created and already replicated at different institutions. And the toolkit is actually designed already for you to sort of grab, and you can read about the intervention. You can read about all the change management that goes along with it and the best practices and all of the evidence for the proper ordering or the proper utilization of these toolkits and actually implement them. And there's a lot of mentorship now that's being offered, which is a little bit about what's new with choosing wisely. But some of them are like lose the tube, or we leave tubes in patients indwelling in hospitals after they get them in the emergency department for longer than they may need. And then transfusion, which we'll talk about as well. I think a lot of you have heard about the PPI overuse. Once it gets prescribed, it sort of just continues on, and then sedatives as well. So this is actually a little roadmap of our hospital at Montfort, going through our choosing wisely journey. And so in 2015, we started to sort of explore choosing wisely, and we've been very fortunate to have a lot of data available to us in real time through Power BI. And so in 2019, we actually became what's called a level 1 choosing wisely hospital. And so if I don't know if a lot of you may be familiar with this, but choosing wisely has sort of created designations that sort of highlight the hospitals or the institution's approach towards becoming a choosing wisely institution. And so we received this in part with the project I described that I went through around that time as well as the imaging testing for the x-rays. And so that sort of helped us get to a level 1 hospital. Fast forward to 2022, and this was not something I was directly involved with, but a really interesting toolkit that we employed at the Montfort was choosing wisely around blood transfusions. So this is sort of their tagline here: make every drop count. Is your hospital using wisely, using blood wisely? And so this was actually a challenge between hospitals. And so there was a study that was done that showed, the liberal use of transfusions. So let's say you have a patient and they made a criteria or threshold of a hemoglobin level. And we ended up saying, hey, why don't we give them 2 units, more is better. And they looked at the mortality rate, 30-day mortality of different types of restricted versus liberal use of transfusion, and found that there's really no difference in providing, one blood transfusion unit instead of multiple, and just reassessing the patient's symptoms. And so there was about 194 hospitals that participated in this movement across the board. And that made up for about 66% of the blood transfused all across Canada. So it's a very interesting study. And they completed baseline audits, and they had benchmarks that we wanted to reach. And so if you can see at the top here, just describing, they want to have at least 65% of your blood transfusions done as a single unit instead of multiple, and at least 80% of inpatient red blood cells having a threshold, a pre-transfusion threshold of 80 as your cutoff, so 80 or less. So that was sort of an interesting project that we sort of tagged along with to say, hey, at Montfort, we're going to try to do the same. And we ended up decreasing our our use of RBCs or transfusions by about 31% since the intervention, and you can sort of see the different periods of time in this chart here of different interventions. So this was quite an interesting achievement in earning the hospital as well a sort of transfusing with care certification. So the tagline in français, c'est pourquoi de produits quand une seule suffit. So they always have some very interesting taglines. So moving along to sort of 2022, where we're again looking at that level 2 designation. We're trying to sort of grow the transfusing wisely, and we talked a little bit about using antibiotic stewardship as well. And so there's a lot of work going on opioid prescribing and antibiotic overuse in the different services in the hospital. And so the part of the journey that we're now targeting is actually to become a hospital to mentor other smaller hospitals or organizations. And so this is something that's quite exciting, and I think really makes sense as part of a choosing wisely journey. It's, we've done things in an institution, and if across the road another hospital wants to try something, I think it's sort of the idea of really starting to share ideas, especially locally, in how to implement some of these changes. The telemetry is our next focus. So, something I'm involved with as well, and just looking at, how we put patients on telemetry, taking up, resources and beds and precious sort of throughput throughout the entire hospital. And so, an audit really revealed that, 20% of them weren't really meeting indications for telemetry, and a lot of them went past the recommended duration of time to be on telemetry. So another interesting intervention that I wanted to highlight. Choosing wisely. So what's new as part of choosing wisely is a new sort of initiative called Lab Wisely. And so this is an understanding between regions and hospitals to sort of highlight the usage per patient of certain tests that are deemed sort of providing of less value. And so, we had an intervention where at our hospital in the ED, we removed certain sort of hard coding additions to your order sets, where you would sort of type in LFTs and you would get everything. And so these interventions we know have worked really well in the past, but now what they're doing is they're sort of trying to compare hospitals and sort of see, and again, so that's that whole thought of sharing knowledge and sort of comparative aspects to see whether or not, we're all in the same area. And I think everyone operates in a different environment, and that's surely to be understood, but it's still interesting. And St. Mike's has done an interesting toolkit that they're sort of hoping to share as well, with reduction of blood testing in routine fashion in the hospital. So sort of, switching to just in case to knowledge-based testing is sort of the tagline there. What I'm currently working on in our department is sort of highlighted on this page. And the reason I went through a little bit of that just to highlight what Choosing Wisely is up to and sort of my journey through it is, how do I piece this all together now? How do we think about, the hard coding activities as part of the implementation spectrum, and thinking about physician behavior and behavior change and audit and feedback? And so what I've been trying to work on in this area of primary care in my setting is to sort of develop about what I try to call a balanced scorecard that looks at different aspects. Because I always hear, with an intervention, if I do this thing, it pulls on this. And if we do this intervention, it affects this, quadrant of care. And so I've done a lot of literature review and trying to identify the great areas of or realms of proper care, which includes utilization and judicious use of resources, but it also includes good patient outcomes and patient understanding. And it includes unintended consequences, such as, return to ED rates or patients that, end up, becoming potentially affected by your intervention. So this is sort of my understanding, is to try to see what are the highest yield metrics that physicians want to know, that they should know about their practice, but not only having these metrics available. So here we have, productivity and ordering, patient outcomes, and sort of unintended consequences. How do we develop a curriculum that can be tailored to physicians who want to seek more information or evidence or help on the areas where they feel that they need to improve on? So what we're trying to do, so this is actually, we've actually automated our scorecard. So we hope to share that across primary care, to be sort of free and open, where you put in data from your center or your practice setting, and you're able to generate automatically a visual scorecard of where you are individually, anonymously as a physician, and where your group is. But it's aside to that, we're starting to create a curriculum where we're identifying the highest yield educational interventions that go along with it, as well as mentorship that goes along with coaching and support. So to deliver really a full sort of product that allows us to, have audit and feedback, but also have support, education, and mentorship. A sort of spin-off project, which has been really interesting in developing our productivity score, we found really difficult, because in medicine, it's really hard to identify or sort of quantify what is productive, because productivity can be meant to mean a lot of different things. But it's not really well studied in this area, and across the US, I know they have different, so they call RVUs, which measures their productivity, but it's sort of, has a lot of cost, and it's not really meant for our system. So we wanted to sort of develop what we call a consensus-based index of productivity for our emergency physicians, to really understand through a variety of different methods, and that's sort of highlighted here, to come with, this is sort of, a baseline literature sample index, where you take a few different things where you can control and things that you can't control that affect your productivity, and to merge them into sort of creating an index to better highlight that for our setting. So that's another sort of side project to make sure that all of these metrics and feedback actually have good evidence behind them before providing them to physicians. So joining the movement, how you guys can potentially be involved in choosing wisely if you're not already. We talked a lot about the toolkits, and I think there a lot of them can be applicable in various practice settings and not just hospital settings. And there's some really interesting toolkits about antipsychotics, and some great examples where province-wide and in different healthcare teams, there's some workshops we're able to reduce their antipsychotic use in long-term care settings, and again through audit and feedback testing. So there's a few good examples within Canada and outside. And this is a really interesting one that I always try to talk to my patients about, and on the sort of the micro level, day to day, right? And so this is sort of the 4 questions to ask your healthcare provider. What is my understanding of my illness? What matters most to me? And how much am I willing to go through for the sake of added time? So it's a sort of critical decision, it's critical discussions, and talking a little bit about those goals, wishes, and values that really help us when they come to the ED. There's a lot of interest groups and collaborations, especially, very excited to see that at this student level with the faculty. And that's something that I support as a faculty lead for the STARS program, which is for students choosing wisely, which is really interesting because you get a lot of perspective from students going through that. They have a sort of a fresh lens on how we practice what we've practiced for many years. I think they're a very interesting untapped area of potential. And I do have a lot of students involved in my research. And I think that's a really great step to sort of have the future of healthcare be so involved and interested in understanding the judicious use of our healthcare resources. And there are specific choosing wisely recommendations for students. And a lot of them involve sort of, talking to staff and asking their staff about why they do things. And so I hope that we as teachers and leaders can consider that in our practice and be open to that conversation with our students as well. So that's the end of my presentation. I think we're hopefully just on time, and happy to hear any questions from the group.
Merci, Rohit. That's wonderful. Thanks for the presentation. and the innovations in choosing wisely. Great updates. So thank you very much. So I'll open the floor to questions. One from Sharon, go ahead.
Hi, a great presentation. Thanks very much. I have tons of questions, but I can follow up with you separately. So I just asked the one, you've established clearly the role or what you're trying to implement in terms of the scorecards for physicians, something I care passionately about. I think probably a lot of us do. Not easy. One thing we don't see a lot of is the next step, either the physicians giving their feedback to the system, in your case, the emergency room, the system that supports them, what do they need to do it? Much harder with family physicians because there is no system for us to identify. As we just heard from John, who do you go to say, where's my patient lost in the knee surgery jungle? But have you looked at any initiatives once your scorecard is done in terms of physicians giving feedback to the emergency room, the support, the system that they need to achieve the benchmarks?
No, it's a great thought, Sharon, and I certainly agree with that. And I don't know if it's the skeptical side of me I have a resident working on this with me. We sort of talk about this a lot because a lot of her ideas are excellent, and they're like, we should have our nursing staff, enter the medications at the triage, and so there's a lot of great system issues. So again, it's sort of preemptively looking at that, which I could expect being a feedback. So certainly, to answer your question, no, we don't have that in place, and I would love to talk about adding a sort of a 360 lens on this. But it's interesting when we sort of look to that preemptively. And I don't know if that's the right way to look at it. And so I've sort of asked her to sort of separate our project into, nice to have system level recommendations versus how can we operate in the current environment that we're sort of left with. And I wonder if that ends up being a bit more of a practical solution. You mentioned family medicine, you can't really change much. So how do we optimize our current environment? And then again, looking at the nice to have, because I found it very difficult to even make the smallest, system level change at the system level. And so maybe that's sort of, my greenness to being in that system, or is it just a nature of why healthcare moves slowly? So, but I would love to explore the idea of, seeing how we can make our physicians, the system that they work in, a bit more efficient, and getting that feedback from them.
Absolutely. And there may be a really interesting opportunity at Montfort as they're looking at linking CPSO QI, choosing wisely. And that's where I really think making sure it's not just the one way, telling the physicians what to do differently, but that this is the opportunity to bake in the feedback and action and measuring it. Is the system responding, so that they're held accountable? In this case, you have somewhat of a closed system that we can do something with, and baking in the accountability of the hospital to its providers. So we'll follow up on that afterwards.
Thank you.
Oh, wonderful. Big thanks, Rohit and John, for your presentations today. We finished right on time. Mia has posted program evaluations for today's session. So please fill those in. Those are important for accreditation. And please join us next month for Family Medicine Grand Rounds. And for all of us that are moving snow today, be careful of your hearts and backs. And I wish you all a good day.